everybody's had a lovely summer break. Uh, and just I just thought, when we were discussing about the topic, and I thought that it might be an idea to have a discussion about the sports injury of the hand and wrist and the elbow. The elbow I chose because elbow is one of those joints which always gets left between the shoulder and the hand and wrist. So it would be an idea to sort of basically tag it along with the hand and wrist, although I'm just going to be touching on some very basic elbow injuries. And also, I thought another area where the therapists sometimes do come across is lesions of the hand. These are sort of one of those things which sometimes the patients might just present for something else, but you might find those lesions. And it's helpful to sort of have an idea of sort of different things which we can see in primary care and which would be beneficial for the patients to be then referred across. Uh, So in terms of broad classification from the sports injuries which we see in the hand wrist, you can classify them into bony injuries and soft tissue injuries. What I have seen in my practice is usually a lot of soft injuries which I see, you see it in a spectrum of patients. It could be the professional sportsmen to the weekend warriors. So it's a different sort of injuries which you'll see in the different groups. But nonetheless, the classification of these injuries pretty much remains the same. And sometimes it can be very specific to what sort of season is going on. Like if there is cricket on, you'll see a lot of hand injuries and finger injuries because of cricket. When there is tennis, you'll see a lot of patients coming in with chronic elbow conditions. And it's kind of a lot of those things also drive the type of injuries which we see in our clinical practice. Some of these injuries can be very sports specific. So you might see a lot of hand and wrist injuries when people doing sports like cricket, more so catching the ball. And a lot of these injuries can also be seen in people like boxing. Again, we can present with a lot of hand and wrist injuries. So again, a lot of injuries or climbing injuries can also be, and as there has been a lot of surge with people doing sort of free climbing now in the last couple of years, more so since the pandemic, we're seeing a lot of those injuries, which we didn't see that often in the past. And a lot of injuries will give you a very classic history. Just to give you an example, many times I'll see scaphoid injuries in people playing football. And usually if you ask them, my first leading question is always, were you in the goal? And invariably they'll say yes. And because many times it's the hyperextension injury of trying to stop the ball, which loads the scaphoid sometimes and results in these injuries. And many of these injuries can have a lot of impact in terms of the personal life of the patient and also in terms of their job. And many times these injuries can be very easily missed. And that's the sort of thing that, again, when you're picking up these things in terms of the history, where you can pick up many of these injuries, and in many ways, it can be a bit of a guide in terms of diagnosing these injuries in terms of the history. And that's why those classic injury patterns are quite relevant. And of course, with many of these injuries, it has to be the diagnosis is made clinically. And then, of course, we use our imaging modalities to pick up these injuries. And now there's been a lot of improvement in sports injuries in terms of surgical techniques and rehab techniques. And that has made that many of these things which were in the past not treated are now treatable. And these are the kind of the common hand injuries which I see in my practice in terms of starting from the tip of the finger. You can have mallet injuries, which is the injury to the extensor mechanism. Then you can have flexor tendon injuries. There can be central slip injuries, which are based around the PIP joint, which can be on the dorsal side. Volar plate injuries would be on the volar side of the finger. Then again, there can be dislocations of this joint. MCP joint injuries can be in the form of dislocations or fractures, or sometimes sagittal band injuries, which I'll show you a couple of videos. And then again, there can be injuries of the phalanges or the metacarpals. And how to sort of do a quick clinical assessment in terms of which are the patients who would need a surgical intervention. As I mentioned about pulley injuries, that's again very seen among people who are doing climbing, and metacarpal phalangeal joint injuries with dislocations at times can easily be missed and are sometimes very commonly seen with different types of sports. In terms of the wrist injuries, I would say you can broadly classify in terms of fractures of the carpal bones, and the scaphoid being the most common one. Then there can be injuries to the ligamentous structures around the wrist. And in terms of the ulnar, so essentially there are problems on the radial side of the wrist and then on the ulnar side. That's another way to sort of classify the other injuries around the wrist. And on the ulnar side, the important structures being the TFCC, along with the ECU tendon, which is inside its own subsheath, and sometimes there can be injuries to that. On the radial side, you have the first dorsal extensor compartment or the second and the third dorsal extensor compartment, where again tendinitis can happen, and that can also present with pain and discomfort. This is just to give you a brief pictorial sort of representation of what sort of injuries can happen in the hand. Just to give you an example of the skier's injury, how the thumb as it goes into wide abduction can result in the ulnar collateral ligament injury. The boxer's injuries, where essentially when you're boxing, you can cause fractures of the fourth or the fifth metacarpal, and sometimes it can affect the other metacarpals as well. Now, sometimes instead of having fractures, you can have sagittal band ruptures, which is responsible for keeping the extensor tendon in position, and that can also happen in boxers. That'll be more of a soft tissue equivalent of that injury. And sometimes because of the repetitive nature of boxing, you can develop arthritis at the carpometacarpal joints here. So these are the kind of different presentations in terms of boxing which you can have. And nonetheless, these things can sometimes be missed. And then obviously it is more in terms of injury inflicted, where if somebody punches on the hand, it could be sometimes a part of the sport, it can happen. And these things should never be missed, because unfortunately, as the tooth goes in, it creates a little dent into the skin and can actually go into the joint and result in a septic joint. And hence, any injury around that area where the human tooth is involved should always be taken extremely seriously. And that's sort of things which should be always sent straight to A&E. And again, you can see here how the ball, when it hits, it can result in a mallet injury. In this case, it can be either soft tissue mallet, where only the tendon is affected, or it can have a bony component with it, and then it is a bony mallet. Again, this is an injury which can happen as it mostly affects the ring finger or the middle finger, being the longer fingers. And usually it's the sudden, when the athlete is trying to grab something, and can happen in rugby. As you can see, the Americans call it the jersey finger. And essentially what happens as you're trying to grab something, it can result in a resisted extension of the finger, and that can drive the pain and discomfort. And the patients usually present, and these injuries can be very easily missed, because normally if they do an x-ray, if there is no bony component attached with the flexor tendon, the x-rays would be normal. But one has to look at the position of the finger, and that's where the clinical examination really becomes extremely critical. So if you look at the finger in a resting position, this finger is sticking out because the flexor tendon is not functioning, and hence is a marker that there's something wrong with the normal cadence of those fingers, and one should have a high threshold to think of a flexor tendon injury. This is just to give you an idea as to how you can assess for this, the functioning of the flexor tendon. On the left, you can see here is the FPL function. So if you just stabilize the proximal phalanx of the thumb and ask the patient to flex, you can assess how much of flexion is taking place there. Then again, here we're looking at the FTS, which affects the proximal interphalangeal joint. So by holding the other fingers, you're defunctioning the FTP and isolating the FTS function. Whereas in this third image here, we are selectively looking for the flexion of the distal interphalangeal joint, which is because of the FTP. So by doing this, you can isolate the individual flexor tendons and check for the functioning of the tendons, so that you can pick up any flexor tendon injury. Mallet injury, as I mentioned before, can be either soft tissue or bony. What we are basically looking here, as you can see in this finger, that finger has dropped down. Again, what we're looking at the x-rays is whether the joint is stable or not. Sometimes you can have a bony mallet, but the finger would still be in alignment, and those ones can still be managed non-operatively. And sometimes the bony chunk would be big and the joint subluxates. Those are the ones would need some sort of a surgical intervention. So obviously, if you come across anything like that, it's good to get an x-ray just to rule out that there is no underlying joint injury, and does the patient need any surgical intervention. So again, with something like that, should be referred to A&E for an x-ray to assess those things. And majority of the times, like I said, they can be easily referred back to hand therapy. And in fact, we set up our first project in terms of making it to be completely dealt by hand therapy, because majority of these injuries can be very easily treated through the hand therapy departments within the hospital. And this sort of then creates a good sort of a care pathways for patients, as they can go into very bespoke splints to begin with. But for some reason, if you don't, then you can always make a splint. And as you can see in this, I tend not to use these splints which are commonly used in A&E, because I always feel sometimes the finger actually goes into a flexed position in those splints and might not give you the best position for that extensor tendon to heal. And sometimes even a simple splint like this, where you're hyperextending the finger, actually gives you a better control over the DIP joint. But again, I normally leave it to my hand therapists, who actually make very bespoke splints for me. And I feel that that provides a better care. And I work very closely with my hand therapy department. So if there are any concerns, they can refer it straight to me if it is picked up through the virtual fracture clinic. Central slip injuries, again, very commonly encountered. And in this, it's again important to sort of assess these, because if these get missed, then there is a risk of developing a Boutonniere type of deformity, where, as you can see in this image here, the finger goes into a very progressive flexion, and that can kind of have a lot of disability in the long term. Pulley injuries, which I was mentioning, happens because of the important A2, A4 pulleys. Because if you can think about it in terms of climbing, and as it has become more popular as a sport, what has happened is that if you don't have the right protection, sometimes the forces which are going through the fingers are enormous, and that can result in the rupture of these pulleys. And as you can see here, the webbing of the tendon takes place. These tendons are important to be nicely wrapped around the phalanx, because when they are in that biomechanically stable position, then only you get a proper function in the finger. And once they start to web up like that, the function, they become really ergonomically not a very functional flexor tendons, and that restricts the flexion. So with these injuries, the sooner they get picked up, the better. They can be referred straight to the hand surgery teams, where initially you can try splinting. Sometimes you might need to reconstruct the pulleys. This is just to give you an idea about how commonly we can see these phalangeal injuries or metacarpal fractures, as we can see here. It really depends upon the fracture patterns and how many of these are injured, so that one can decide in terms of what is the best treatment. But these are the sort of simple tests which can be done whenever you see these patients in terms of alignment. Normally, if there is a fracture, but if the alignment is of all the fingers pointing right towards one sort of plane, literally in position with where the scaphoid would be, then usually one can say that there is no significant malalignment, and those injuries possibly can be treated non-operatively in line with what other associated injuries are there. And here you can see, as the two fingers are diverging, that should be a good marker to sort of make you think that, look, there is some sort of rotational deformity or angulational deformity which could be running the problem, and these needs to be urgently seen by the hand surgery team, so that if they need fixation, then that can be done. Sagittal band, again, in this case, I picked up a slightly elderly patient who had an associated inflammatory condition. I could not find a slide to show you in terms of post-trauma, but I have seen this a lot of in the sports injuries. In this particular patient, there were multiple extensor sagittal bands were involved. So you'll see here that the patient is unable to extend the fingers. So essentially, with a lot of support and think they can flex the finger, it's just because the sagittal bands are responsible for keeping the extended tendons in a stable position. And once that stability is gone, the extensor tendon really drops between the knuckles. I tend to do this surgery under as a wide awake procedure under a local anesthetic, so you can clearly see here how you can actually assess it whilst the patient is having the repair done at the same time. A lot of my practice in terms of extensor tendon is based upon wide awake surgery now. The other common injuries in terms of the thumb, which we see, is the skier's thumb. Again, when people come back from the skiing season, you can see these type of injury, but nonetheless, you can see it in different types of sports. I've had patients who have done this type of injury, doing football, rugby, falling over and stretching the thumbs, going into that sort of abducted position and rupturing the ulnar collateral ligaments. I've seen people doing it whilst doing canoeing, other sort of sailing even. And as you can see here, the thumb gets very unstable and literally starts, as you can see in this image here, it's falling off from the metacarpophalangeal joint there. And essentially, if you go in there, I mean, invariably, if they come in as an acute, then we would repair them or splint them depending on the degree of injury. But as you can see in here, if they can be chronic injuries where there is a marked instability, and I'll show you another one here recently, there's a lot of movement which is there, and the thumb becomes a very unstable post, and you can't do the pinch. and these movements which involve like turning keys, opening jars, and produces a lot of disability. In a chronic situation, acute, like I said, you can straight away repair them. You can use very special anchors which are available now to do it. But I'll just like to show you this one again. This one was very strange because as you can see here, how the thumb is literally dislocating and falling off with every time the patient is trying to do a movement. And this, in an acute condition, as I said, you can repair it. But in a chronic condition, I tend to take a little harvest a graft from the flexocarpi radialis, and then I would go around there and I repair it. And we can now use very special anchors with which we can do a full repair. There's no need to put any sort of screws or any other metalwork in there. And usually they can rehab very well and gives you a very good function. It's only when they present late that they have got underlying arthritis that you have to start thinking in terms of fusing this joint. So again, it's important from a clinical point of view to have a high index of suspicion with these injuries so that they can be picked early and they can be treated when it is relatively simple to treat rather than when it becomes more chronic. In terms of Dicker veins is another common condition which we see in any sports, very common among, now obviously, people who are playing sports like using the PlayStations and all with the repetitive movements, and all those things also cause a lot of movements on the tendons inside this first extensor compartment. I see a lot of in the teenagers who are using a lot of mobile phones, maybe playing games on that rather than sort of doing proper sports. And also quite common among young women, young mothers, and it's also called the mothering thumb. But essentially what happens is with these repetitive movements, which can be involved in any sports, you can get that inflammation there. And these are the different tests you can use, which is this one being the Eichhoff test or the Finkelstein test. But the whole idea is you're just stretching the tendon as it is passing through the pulley where there is a stenosing tenosynovitis picture. And by loading the tendon, the patient will complain of pain and will localize to the first extensor compartment. Usually with these ones, once they've tried a period of maybe non-steroidal drugs and tried tendon glides, which they can look online, or you would have prescribed them through your practice. If the symptoms do persist, then they might benefit from a steroid injection. In a small percentage, roughly 20% or so, where it is recalcitrant to non-operative treatment, you might need to do an open release, which again can be done under a local anesthetic. I just put up this slide here just to give an idea in terms of the wrist as to where it lies in terms of the structures in the bones. So if you think about the wrist, it extends into the distal forearm there in terms of the bones. So a lot of signs and tenderness which we're looking at is actually beyond the hand and extending into the distal forearm. And that sort of takes us on nicely to the different ligamentous injuries which we can see inside the wrist, and the most common being the scapholunate ligament. It's a bit more of a generational thing, but if you can call it the Terry Thomas sign, but obviously the young generation probably won't remember him, and you can probably call it the Madonna sign or something else. Or maybe as time progresses, we'll have different pop stars, we can use their name. But essentially what it is that there is an increase in the scapholunate interval there, and that sort of dissociates the movements within the carpal bones, and that results in instability. And if this is not picked up early or treated, then there is always the risk of developing arthritis in the wrist, which is called the slack wrist or the scapholunate advanced collapse. I just thrown in this in terms of examination of the wrist. So essentially, this is just to sort of show you a simple sort of range of movement you can check. And if there is any sort of ligamentous injury or any injury to the wrist, you will see sometimes that there could be a slight restriction in those movements. So in my practice, I'll check for dorsiflexion, palmar flexion, as you can see here. But at the same time, I'll also ask them to pop their forearms on their thighs and put the thumbs up, which is like a bit of a measure, and then ask them to do pronation and supination to look at the rotational movements as well. In terms of the scapholunate, we can do the Kirk-Watson test and go from palmar flexion to, from radial deviation to ulnar deviation, and that sort of will show any instability at the scapholunate interval. The other common thing we can use is to look for tenderness in the crucifixion fossa. Now, the crucifixion fossa is just distal. So if you feel at the back of your radius, you'll feel a very prominent point, which is the listed tubercle. And if you just walk along distal to that, you'll fall into a little fossa, and that is the crucifixion fossa, where the Romans used to stick the nail for crucifixion. It's just because that is a very strong part of the wrist. And essentially, if there is any scapholunate ligament injury, then usually patients will have tenderness there, and that's where you put your finger when you're doing the Kirk-Watson test as well to check the instability. In an acute condition, you can always repair it. You just go in there, you find the ligament. In the first 3 to 4 weeks, the ligament is strong enough and you can repair it. But if you are in a chronic situation, then usually beyond sort of 3 to 4 weeks, usually the ligament is not of a very good quality that it can be repaired. And in those ones, especially if they're very unstable, then I tend to do a scapholunate ligament reconstruction, which would involve taking a part of the ECRB tendon from. So essentially, I do it all through a posterior approach, so I don't have to make incisions at the front. This has all been possible because in the last few years, we have been able to get better anchors with which we can create these ligaments. So as you can see, there's a dorsal reconstruction has been done, and they usually are then protected in a splint for 3 to 4 weeks. And then after that, they start with very guided rehab with the hand therapists, and usually are in a protected sort of a splint for a period of 6 to 7 weeks. Scaphoid fractures, as I mentioned, very common injury is because of the forced hyperextension in the wrist, which can drive a scaphoid fracture. And as you can see here, the reason why we worry about the scaphoid injury is because the blood supply, as it is from distal to proximal, there is always that risk of the scaphoid going into an AVN or avascular necrosis. This is just a simple test which can be done by just comparing the two wrists, and you can see here on the right side there's a bit of a bruising, but also there is fullness of the anatomical snuff pause as compared to the opposite side, and that has again shown as a good marker in picking up a scaphoid fracture. The other thing is to feel for tenderness right in where I mentioned the crucifixion fossa is where the proximal pole of the scaphoid is. You can check for the tenderness there. You can check for the tenderness in the anatomical snuff box. And if you feel for the FCR tendon here, where it ends, you can feel that scaphoid tuberosity. And then you can actually load the scaphoid from here. And if any of those things is positive, roughly if 2 to 3 out of those 4 which I've mentioned are positive, then there's a high index of suspicion for a scaphoid fracture. And those are the ones they need to be referred just for the proper imaging so that we don't miss any scaphoid fractures, because if we do, then there is a higher risk of developing what is known as a snack wrist or scaphoid non-union advanced collapse. This is just to sort of show you how we can do a percutaneous fixation of the scaphoid, literally through a small little cannula. I can fire in a wire, and then through over that, we can do literally almost a sutureless surgery, which involves putting in a screw. But in my practice, I'll only do it if they haven't responded to initial period of non-operative treatment, because there's a significant portion of patients do get better with that as well. Then obviously, depending on the nature of the fracture pattern, I will be deciding whether they need fixation or not. This is just to give you an idea as to how the scaphoid arthritis of the wrist can present. On the left, you can see is a slack wrist. On the right is a snack wrist, which is a scaphoid non-union advanced collapse. But nonetheless, both of them can produce arthritis of the wrist. And if the patients do end up in that situation, then they'll either need a fusion or a replacement of the wrist. Wrist replacement, again, is a very specific procedure only to be done under very research sort of settings. It is not sort of like a hip or a knee replacement or a shoulder replacement. So in my practice, patients have to fulfill certain criteria, and then they go into the research protocols are fulfilled, and then they go ahead with a wrist replacement. This is just a patient who had a wrist replacement.
What do you think about the wrist?
Well, I'm pain-free, apart from the arthritis, I'm pain-free, so that's wonderful. I can knit, I can sew, I can peel vegetables, I can hold them after a fashion.
So essentially, although the wrist replacement is transformed, but nonetheless, it is still not sort of the treatment I would offer it to the younger patients. It'll be pretty much for the people who I think would be the right candidates for that. But nonetheless, there is a huge improvement which has happened in this field and will continue to happen. And I'm sure that'll be something which will definitely improve with time. Now, the ulnar-sided wrist pain is mainly sort of driven by injury to the TFCC. It is called the triangular fibrocartilage complex, but it essentially consists of structures around this ulnar corner, including the ECU tendon and this trampoline-like structure, which extends from the distal border of the radius and then extends into the ulna. But it's responsible for the stability of the distal radial joint. And unfortunately, with these types of injuries, there can be sometimes instability in the distal radial joint, and that's the reason why many of these patients would present to my practice. Sometimes these injuries can happen in an acute situation, or sometimes they are missed in an acute setting, and they usually present to my clinic as much more chronic injuries. Again, on clinical examination, you unload the wrist, the patient will complain of pain there, or you feel for the tenderness here, which is called the fovea. It's called as the foveal sign. And essentially, if it is, again, depends upon how severe it is. If it is a mild to moderate degree of tear, then you can try non-operative treatment for partial injuries. It's the patients who are not responding to non-operative treatment sometimes might need further imaging, and obviously depending upon how much it is disabling them and what the imaging shows, there are different types of treatment. I tend to do them arthroscopically. Sometimes the MRI scans might not give me a true picture, and that's the thing across the whole wrist. MRI scans sometimes are not very specific in terms of picking up lots of injuries, and many of these patients would then subsequently end up with having an arthroscopy. And on that, if it shows things, then we can do it at the same time. We can do it arthroscopically or arthroscopically assisted. What has definitely changed in my practice in the last few years is now the use of the nanoscope, which basically means that because they are easy to use this nanoscope, I can go into the wrist, I can investigate, and I can treat at the same time. Because initially when I used to do arthroscopy, because of the fluid which used to go in, I had to do it as a two-stage procedure, but this has enabled me now to do it pretty much at the same time. ECU tendon subsheath injuries are again the sort of thing which I see quite commonly. I've seen in my practice in people doing martial arts, and I think it's sometimes sudden movements, or people doing racket sports as well sometimes can present with this pain along the ulnar corner of the wrist. And with these ones, what I have seen is usually it can either present it as an acute setting, or maybe at a majority of the times what I have seen is that the injuries get missed and then do present to my clinic as more like a chronic injury. I tend to use an MRI scan as my initial tool of looking at these things, and I can easily sometimes see this kind of increased signal around the tendon and fluid, and that will show me what's happening with this injury. But nonetheless, sometimes it might not be very diagnostic, and then I'll put them through what is known as a stress or a dynamic ultrasound testing, because many times I've seen with sports people, is especially when they're doing certain movements, or after having done certain set of movements, that they usually become more symptomatic. And the dynamic ultrasound scan becomes quite effective for me to pick up these injuries with those patients. Just to sort of give you an idea as to how it feels like, you'll see a very subtle click there. And that subtle click is the tendon flicking in and out of its pulley, and that sort of sometimes drives the problem. And in an acute situation, you can always repair it. Sometimes you have to probably take a slip of the extensor retinaculum and reconstruct the pulley for the tendon so it is stable within that pulley. I have also seen in these chronic conditions where there's a lot of synovitis around the tendon, you literally have to debulk the tendon, free it out of that synovitis, and then to repair the extended sleeve back to the bone where it belongs. And as you can see me putting those anchors in and then repairing and creating a pulley after I've decompressed the tendon. EIP to EPL transfer, sometimes these injuries can happen again with sports people who have got distal radius fractures. Commonly, you'll find these injuries with people who have got undisplaced fractures. For some bizarre reason, it's like a compartment syndrome of the EPL tendon, and that can result in a delayed rupture of this tendon, usually 6 to 8 weeks following the fracture, which I've seen it in my practice. And that's what the literature would show as well. And with these ones, you end up doing EIP to EPL transfer. This is a patient, I think I saw her during the pandemic. She was a few months following this transfer. In this case, she had a fracture, although she didn't do it doing sports. I think she just had a normal sort of a fall, but I just sort of thought I'll just bring it along and show it to you what an EIP to EPL transfer would be like.
In your own words, how do you feel this tendon reconstruction has helped you?
Absolutely wonderful.
I'm so glad it made a difference. Put your hand down and show us how you can lift your thumb up now. Good, excellent. And all those fingers are moving nicely. Brilliant.
Now, if I turn it that way, I can go up.
Tell me in your...
So the whole idea there is that to show you that if the disability which a dropped thumb can do is phenomenal. Thumb is almost 40% of individuals' hand, and if that function is not there, it really makes life quite miserable for many of these patients. And usually the ones who come to my practice are usually the ones that have been chronic injuries. They've been through the sort of the normal sort of the mill of getting from one place to another, and then eventually they'll come to my practice. And what I've seen with these patients is majority of them do very well. I mean, obviously they might not have the full strength because it's a tendon transfer. You always lose one MRC grade in terms of the strength, but nonetheless, they have very good function. The thumb goes into a much more functional position and they do very well. Then I thought I'll just throw in these few things. Sometimes you might see patients and you'll see, you know, they come in with different lesions and they might just mention in the passing, oh, by the way, I've got this. And sometimes with the hands, if you're seeing them, you might be able to guide them. This is just to sort of show you how the things, this is a simple wart. There's a non-healing one, and I think this one was probably referred from dermatology. And you just go in, then excise them. Anything I excise in the hand, I'll always send it off for biopsy, and that usually would confirm whether it is a skin lesion or it is a virus, because they'll do viral stains and stuff. This one I thought would be a good one for you to sort of see. If you look at this finger there, there's a big furrow within the nail, and this was again referred to me for a non-healing sort of an ulcer there, but essentially this was nothing but a mucoid cyst. A long-standing mucoid cyst presses on the germinal matrix of the nail and produces this growth deformity in the nail, and that results in this furrow. So you go in there, you just excise it, send it off for testing just to make sure that you've not got any underlying squamous cell carcinoma or something, because sometimes that can be a differential for these non-healing sort of ulcers. But invariably, if it's nothing to sort of worry about, then usually if there is pain and discomfort in the joint, then you end up fusing them. These are the other different types of treasures I found inside the hand. This was quite a big lipoma. I think this was like 3 centimeters. It's probably one of the biggest lipomas. It was like a collar stud, which literally goes onto the dorsal side of the finger as well. She did very well following the excision of this massive lipoma. She had a full range of movement. This is again a viral wart which has caused keratosis. So if you look, it literally has lifted the nail up. And I think again, this was referred from dermatology. You go in there and you excise these ones, and usually they get better. That's another view of that. This was an osteochondral lesion which came off from the side of the finger there. Again, it was coming in the way because the fingers, he could not actually bring the fingers together because it was quite a big lump and could not make a fist. This is a neurofibroma right down rising from a digital nerve. This is another neurofibroma which was coming from the nerves within the palm of the hand, approximately 2 centimeters. These sometimes you can have these sort of tumors, and you can sometimes see it within the nail bed as well, where they can be extremely painful, called as a glomus tumor, and these can be quite painful, and you know, you just end up excising these. But these are the ones which are quite the nasty ones, the melanoma. These can present as a pigmented streak right down the nail. And if you see any of those ones, I would get them to a dermatologist or to a hand surgeon under a 2-week rule. Just want to make sure that you don't miss any of those ones. I come across different things in the hand. This was a hiradenoma, again, a non-sort of healing sort of a lesion inside the hand. There are different sort of things. I mean, most common things we'll see is sometimes is inclusion sort of cysts or foreign body granulomas, because hands are the first contact with the environment. So many times in sports, many of the sports people would just be, you know, your hands can get injured, and that can also bring on these types of lesions. In terms of the elbow, the common sort of things which we see are the acute ones are dislocations, common dislocations, simple dislocations where there are no associated fractures, but there can still be a lot of ligamentous injuries associated. And if you see any of the patients who've had an elbow dislocation, but they still continue to have pain, would definitely should be referred on, because they need an MRI scan to rule out any underlying ligamentous injuries, which can present itself with problems in the long term. And then obviously the ones which have associated fractures will obviously end up in A&E. This is just to sort of show you that what sort of spectrum of dislocations you can, from the good, the bad, the ugly. So it's just to kind of be aware of this. On the extreme right is a terrible triad, where there will be an associated fracture, ligamentous injury, and the sort of the full house of a dislocation. There, like I said, in many of these sports injuries, the biggest thing which has happened is the development of different implants with which we can treat these injuries, and I think that's kind of what's driven the whole sports injury surgical side of things. With improved rehab, is the use of different tools with which we can repair. And again, you can see we can do chronic, acute, we can repair them. In a chronic condition, we can reconstruct these ligaments. Again, common things which you'll see is the tennis elbow and the golfer's elbow, one being on the medial side, the golfer's elbow and the tennis being on the lateral side. Treatment, again, would remain non-operative to begin with. They usually would have done the these things by the time they come to my practice, but I would have expected them to have done eccentric strengthening exercises for the respective sort of muscle groups, depending upon which side it is. And then if they have failed all the things, then usually in my practice, I'll still try a PRP injection, and invariably that does work. Almost 50%, although I find in my practice is definitely better. But if you look at across the literature, that pretty much is the ballpark figure. Again, if that does not work, then only I will undertake any surgical intervention in these patients. But I have to say the non-operative treatment does reasonably well. That's just to sort of throw in a patient I'd seen just a few weeks ago who had a distal biceps rupture. Again, a common injury which we see with the biceps tendon. He is a professional boxer and he had ruptured his distal biceps on the left side. You might be able to see here, there's a small scar here. And normally what happens is as this biceps tendon ruptures, the biceps tendon climbs up here. He was supposed to have his first professional fight, but because of the lockdown and the injury, I ended up fixing him, and then he went back to doing his professional boxing again. But with these sort of things, now because of the improvement in surgical techniques, we can do these procedures through really almost very, very small incisions and with very good outcomes, especially if you can pick them early. Unfortunately, these injuries do get missed sometimes, and I will pick up many of these patients who are symptomatic as chronic injuries. Those ones are then definitely much more complex to treat, as I'll have to use allograft to repair those things. I haven't touched on because there are other sort of many associated injuries of the upper limb, but I think this is just a kind of a brief overview of the common sort of upper limb injuries which you will see. But I'm sure at the back of this talk, if there's other things which the group would like, then we can always go back to sort of discuss them in more detail. Thank you very much.
Thank you very much, Mr. Mohan. That was brilliant. There aren't any questions yet in the Q&A or the chat function. If anybody wants to ask Mr. Mohan a question, I'm sure he's very happy to answer. You can give it another minute or two.
Yeah, sure.
I don't see anything coming up.
Complete silence.
Everyone wants to enjoy the last little bit of summer that we've got.
I think that's probably what's driving it.
Well, I hope that you all have, oh, wait, hold on, maybe one question. Oh, it's the, what's the from Sam, what's the threshold for TFCC surgery?
So essentially, I tend to take them on a case-to-case basis. The patients who have been symptomatic would come to my practice, and I would basically start with a simple MRI scan to assess the degree of injury. Now, if it is only a partial injury, then I tend to be more non-operative in my approach. But that said, if there is a significant partial injury or there is a complete rupture of the TFCC, then I'll discuss the surgical option in the form of arthroscopy. Like I said, I mentioned about the nanoscope. Now, with many of those things, you can literally, if you want, you can do it under a local anesthetic as well to assess it from inside. Then you're in a much better position to see how bad this injury is. And this can be treated arthroscopically assisted, or if there is a confluent injury of the other structures associated with it, which can happen, and I have seen it in my practice, especially with sports people, then I will do it as an open procedure. But I can pretty much do all of that in one sitting. What I do tend to tell my patient is the rehab is quite long with these injuries. They are in a restricted splint or a plaster for a period of time, and then they start with a very graded strength training in their wrist after that.
There is another question from Ravi. What is your view on steroid injections for tennis elbow, and how many before a referral to you?
So in my practice, I would never use a steroid injection for a tennis elbow. I haven't used one for the last almost, I think if I can count it correctly, well over 8 years now. So in my practice, and there are studies to support that if you look at a 1 year mark with anybody with a tennis elbow, if you don't inject them, or if you inject them, the outcome is probably worse if you give them a steroid injection at a 1 year mark. And the randomized controlled studies have shown that. I personally believe in the ligamentous stability of the elbow, and I think repeated injections or unnecessary steroid injections can cause damage to the lateral ligament complex of the elbow and can create a picture of micro instability inside the elbow. And it literally, if you look at the evidence which has come through, that the tennis elbow, there is no inflammation as such. It is more of a tendinopathy. And by putting in the steroids, we're weakening those tendons even further. So there is more substance and more evidence to just do physiotherapy rather than giving them steroid injections. So I know it's painful. I encourage my patients to take painkillers and carry on with exercises and eccentric strengthening exercises in particular. But I would not inject a steroid. Yes, if I have to try something, then I would do a PRP. And I offer them, I usually am guided by how they respond to the first PRP. If there is a partial response, then I will give further PRPs. But I don't blanketly give 3 PRPs either that often. That's pretty much what I see in my practice. But then, of course, there are people who would not respond to non-operative treatment, and they are the ones usually will end up having open tennis elbow release with a reconstruction. I hope that answers the question with the steroid injection.
Thank you. There's another question from Sam. A 40-year-old female with ECR tendon tears. She's not suitable for injection. So what is the option if it's a chronic condition? And just to add that she has bilateral tennis elbow.
So when you say which particular ECRB tendinitis, or you're talking about Dicker veins, can Sam clarify whereabouts is the pain?
Just wait for Sam to respond. The extensor tendons of the elbow.
Okay, if it is just the tennis elbow, and if you've tried non-operative treatment and physiotherapy at all, even if they've had a steroid injection, I would say at that point, I would try a PRP first. I still have a very open mind in terms of PRP. And then I know that I have given the full trial of non-operative treatment, and then I'll proceed with further treatment in the form of maybe if the non-operative is not working, then consider surgical intervention. I think what is important definitely is to confirm the diagnosis. Because sometimes patients can have underlying, I mean, I've seen it in my practice, people who have been treated for tennis elbow, but actually might have radiocapitular arthritis underneath it. So, and that's the reason why with many of these patients who have got recalcitrant symptoms would get first an imaging before they get any treatment. And the MRIs can also help me to grade the tennis elbow, whether it's mild, moderate, or severe. And that can also help me to decide whether it will respond to non-operative treatment or not. And that sort of helps me in shared decision-making with the patient. And then maybe if it shows that it's a severe type, non-operative treatment hasn't worked, and PRP has been tried and not worked, then maybe we consider the surgical intervention in those ones.
I think that's all the questions that we have. So thank you very much, everyone. We hope you have a lovely evening. Thanks for joining us. Take care.
Thank you.